Hi everyone, welcome to our podcast. My name is Dr. Sean Nikravan. I'm a board certified endocrinologist, internist, and clinical lipidologist with 25 years of experience. I have the privilege and the honor to introduce to you Dr. Sanaz Karami, who's a well-esteemed internist, highly trained, highly educated, and I can tell you she is a phenomenal physician. Her patients love her. We're very lucky to have her here today to have experience regarding a very common symptom we deal with, which is male hypogonadism, low testosterone.
Thank you. It's a pleasure to be here. And it's so nice to be in presence of an expert, someone who really knows this matter. And what I want to do is just get some of my questions and questions of what everybody has on their mind answered. Testosterone is all over the media, and everything you pull up, low testosterone, it's the magic trick, it's the anti-aging, you look younger, you look great. Is this true? How valid are all these claims that people make about testosterone?
You're absolutely correct. Testosterone clinics are popping up for many years all over the place, and they are claiming to be the anti-aging youth muscle growth clinic all over the place. So there is some merits to it, and there's lots of fallacies that go with it.
So, first thing first is, I see a ton of men who come into the clinic and, they've heard about testosterone. They come in there, I'm tired, my libido's low. Does everyone get on testosterone? Like, how do you decide who is a good candidate for testosterone replacement?
Well, great point. Testosterone has two functions. The first function of it is sexual, which is the libido, the sexual drive, the oomph to chase the opposite sex. The other aspect of it is the functional aspect of it, which is I feel good, my energy is good, my stamina is good, I'm okay to do housework, gardening work, I want to go out, do stuff, I want to do things. So the question is which symptoms you have, because you could have other problems. You could have problems with your thyroid, you have problems with the adrenal gland, you could have problems with depression, you could have problems with sleep apnea. There's a lot of different things that give you the fatigue symptoms that mask testosterone deficiency.
That makes sense. That's probably one of the reasons a lot of patients get on testosterone, and then they come back and they're like, I feel a little bit better, but I still have some of the same issues. So I guess if you're not dealing with some of the other underlying issues,
correct,
it's not.
So it's very important to go on testosterone if you're truly testosterone deficient, because if you take exogenous testosterone, what happens is your own testosterone level, no matter what it is, will go basically to a negligible level. Your body's like, wow, we have testosterone in the blood circulation, why do we need to work? So your testes go to sleep, and that causes...
So you essentially are shutting off your own testosterone production.
Absolutely. You have good production. The question is you may not have enough production. There are things you can do to augment your endogenous production. That means what you make on your own, because if you get testosterone from externally, you shut down your own production.
I see. So now, that being said, what is the way to determine, what are the steps that you take when a patient comes to your clinic to determine, are they a good candidate? Is this someone who should really get testosterone?
Well, if the patient presents with clinical symptoms of hypogonadism, meaning low testosterone, the very first thing the doctor needs to do is get a good history, making sure there are no other problems. Take a very thorough history. Just don't look at the lab, because there could be other things creating that low testosterone. Once your doctor has fully evaluated your case, taken a good history and examination, then the doctor should do a morning testosterone, like around 8 o'clock, 8 to 9 o'clock. They shouldn't do a testosterone after 10 o'clock because testosterone levels drop. So a fasting testosterone at 8 a.m. and then repeat it once more for validation.
Now here's a scenario for you. I've had many patients who come and they have the classical symptoms, a low libido, they're fatigued, they're not building muscle, and we do the test and the testosterone actually comes back in the normal range. It's somewhere like in the 400s or high 300s. Are these patients that can still get testosterone?
There is a concept called relative hypogonadism. We all can agree that if testosterone is over 400 nanogram per deciliter, it's pretty much not a problem for you. Levels between 300 to 400 are debatable. We can all agree that levels less than 300 is classical of hypogonadism. But the most important question your doctor has to ask is there a reason why testosterone is low? But more importantly, what is your baseline testosterone? So I always urge patients who follow up with their primary care doctor to get a baseline testosterone, even if they're feeling great. Get a baseline testosterone, because we need to know where you were when you're in your 30s, in your 40s, because if you're in your 30s, you wind up with testosterone of 600 or 500. When you're in your 50s, there's a good chance your testosterone will drop 1% per year at the age of 30 to 40. So you can drop. Now, if there is comorbid conditions like you have diabetes, high blood pressure, illness, that testosterone can accelerate regarding its decline. So it's crucial to know where your baseline is when you're at your healthiest state, so your doctor can gauge, if my testosterone is at 400 at the age of 35, there's a good chance I'll be low somewhere in the 50s.
So that's interesting you say that, because I actually have it as part of my panel for all of my physicals that I do check a testosterone level. And I have patients who often will actually get even a testosterone in the 200s, which is, considered absolutely low, but they feel great. And then they say, well, what should I do about this? So, I usually tell them, if you're not symptomatic, you don't treat it, but what's your opinion about this?
So testosterone is a very important hormone for many things. Number one, for bone. It helps build new bone. So the bone cells that are new bone are osteoblast bones. They help produce new bones forming cells. The next thing, testosterone helps produce red blood cells. So there's a lot of patients who go through this $1 million workup by their doctor, and they have all these they can't figure out why this patient's anemic. They have this low-lying anemic, they can't figure out what's going on, they're lightheaded, they're just not right. And those are patients where testosterone deficiency can play a big role. So we don't like testosterone to be in the 200s, and we have to ask, if you're that low, is there a secondary problem? Do you have a pituitary problem? That's a very important question you ask.
But if they are low and they feel fine and you don't find any of those problems, when you do their workup, would you just...
Well, I would educate the patients very carefully about what the symptoms of hypogonadism are. I would explain to them what those symptoms are. And they need to look at it very carefully, because sometimes they may be so busy with their life, they're moving around, they're busy with their kids and their family and their obligations, they just forget about it.
Right.
And men typically don't like to complain. They just kind of tough it out. I'm a tough guy, tough it out.
Yeah, usually by the time they come in, something's really
gone
wrong.
So you educate them about what those symptoms are. And if they truly have symptoms, they may have low symptoms. They say, you know what, my role in this care is that, you have these symptoms, but why don't we just maybe we should stimulate your production. Maybe we should do something to augment your testes to work better.
So how do you do that?
Well, there are different ways we can do this. We can use fertility drugs that block the pituitary receptors at the brain signal at the pituitary to augment increase in LH and FSH in the pituitary, which then...
And that's just like a one-time thing?
Yeah, it's a one-time thing. We can boost the testosterone for several days to a week or so, or 2 weeks, and that helps increase testosterone on their own. Or we can directly give them HCG or pregnal drugs like that through a protocol that helps them increase testosterone production at the testes. So we say you were feeling great, you think you were feeling great at 250, but now your levels are like 550, 700. How do you feel? Like, oh my God, I had no idea. I felt so much better.
That's interesting. That's really interesting. Sometimes you've been fatigued for so long, or you haven't had energy, that it just becomes your norm and you really just think, this is it. Oh, it's because I have kids or because I didn't sleep, but really there is an underlying reason.
Exactly.
What about side effects to this?
Well,
People always worry, am I going to get cancer if I get on this? What are the side effects of testosterone replacement?
That's a wonderful question. When a physician puts patients on testosterone therapy, or any therapy, the benefits have to be here and the risks have to be here. The benefits-risk ratio have to matter. So the very first thing we worry about testosterone can cause thickening of the blood, because testosterone that your body produces naturally is in a circadian rhythm. It goes up and it goes down, it goes up and down. It's not a constant stimulation. When we give testosterone through exogenous methods, being if it's a injection or if it's a cream, whatever we give, that causes a continuous stimulation, and the bone marrow gets the continuous stimulation. People get thick blood, hyperviscous blood. They get thick blood, and that increases the risk of blood pressure, fluid retention, edema. That could worsen sleep apnea. There's debate about cardiovascular outcome data about that too. There's question about prostate. You can get prostatic enlargement. You can get enlargement of your prostate. Your PSA can go up, thickening of the blood. You can also get elevation of estrogen, which is unwarranted. You can get breast tenderness. So you really have to be careful who you give testosterone based on the risk profile.
My understanding is that you cannot get prostate cancer. However, if there is a prostate cancer that's brewing, this can actually bring it forth and make it grow faster. Is that correct?
Correct. While we were training years and years ago, we knew the data very carefully. Testosterone doesn't cause prostate cancer. That I can tell you, it does not cause prostate cancer. But if you have the propensity or risk that you have prostate cancer that's dormant, and you give testosterone, you can accelerate the growth of that prostate cancer. And that's also now in debate regarding if you have prostate cancer, you have prostatectomy, you have the prostate removed, when should you start testosterone? Very important question, because now you take an 8-cylinder engine, now you take 7 cylinders away from a guy that's living an active lifestyle. And now they have prostate cancer, you deal with the prostate cancer. The role is, when do you reinitiate testosterone? Are the margins clean? What is the Gleason score? What are those numbers? What is the risk factor? What's the quality of life for patients? Because patients, I can tell you, will become extremely miserable when they lose their testosterone production.
Absolutely. I mean, that's just the biggest thing right now is, forever we heard about menopause and females, their hormones going down, and there was never much talk of andropause, which is the equivalent of menopause for men. And now people are living longer and they want to live more productive lives. They want to, they're living into their 80s and 90s, and they want to be able to play sports and, have sexual relations and really have that energy. So having, the hormone replaced, because it does go down for almost everybody, right, throughout
Correct.
their life.
Testosterone drops about 1% between age of 30 to 40, 1% per year. So it depends on where you start. You can have a 20% reduction of testosterone. If you're at 600, 20% of that will be significantly reduced. You may have symptoms. But as you get older, there are other things that go wrong. Your thyroid may get weak. You may have less serotonin in your brain. So it's more likely you'll develop endogenous depression because of lack of serotonin. Therefore, you may need drugs that augment and increase your serotonin production, so they have less serotonin deficiency in the body. So you have now fatigue, you're older, your muscles are weaker, your testosterone is lower, you're more depressed because your serotonin levels are down, your thyroid is not working well, you're sleeping poorly, you're not eating well. All of them confound together to create a major symptoms. And that's why I worry about, because all these testosterone clinics are popping up. They're promising the patients the world. They're saying, I'm going to put you on testosterone, I'm going to charge you all this money, and guess what? You're going to feel great. You're going to go on it. Initially, you'll feel good for about 2, 3, 4 weeks, and after that, you're like, oh my God, I don't feel good anymore, because they never address the underlying problem.
Well, I mean, that's, just like you said, that's the important part about being treated by a trained professional. There's tons of benefits to it, but just like with anything, it is a medication that you're taking, and you need to have a trained professional that's monitoring the levels.
Absolutely. I want to present to you a case that really breaks my heart. A few months ago, I saw a patient that was on testosterone therapy. He went to this testosterone clinics, and he was given testosterone because his testosterone was 190. He goes, oh, your testosterone was low. The guy was in his late 40s, and they never asked why. They just put him on testosterone, saw a mid-level, put him on testosterone, and then the patient came back, with no symptoms of improvement. He felt better with testosterone therapy, but after several months, he noticed that he's not feeling that great. He's getting some headaches, and then his buddy's like, you know what, you should go see a doctor, go see a trained professional. The patient came online, looked at us and said, I'm not feeling well. And when I examined them, I got a very question. I go, your testosterone was 190 nanogram per deciliter on presentation, and you were put on testosterone just like that? He goes, yeah, they put on testosterone. And as I was examining him, I recognized that he had lost peripheral vision. When I was examining him, he could not see his peripheral vision. As I came close to his eye, he had no peripheral vision. I was like, wait a minute, this is not right. You're in the late 40s, testosterone 190. There's got to be something else. So I got very suspicious, and I ordered some pituitary labs. I got his prolactin level back. Guess what it was? 5,600. It was so high. At that moment, I knew this guy had a pituitary tumor.
Adenoma, right?
Exactly.
Yeah.
And so guess what? This patient had pituitary, we got a pituitary MRI on him. The pituitary mass was so big, it had gone from his pituitary, it had blunted his optic chiasm where it takes signals from the brain. That's why he couldn't see any well. His vision was going. It invaded into his brain vessels, the cavernous sinus. So we had to consult a neurosurgeon. We had to put him on medicine specifically to debulk this thing, get him smaller, and that could all have been prevented because he was on testosterone therapy for several months, and this thing was growing. I had no idea how long he had this tumor.
Yeah, I mean, and that's just, highlights the importance of really doing the workup before you start a patient.
Correct.
On something such as testosterone that seems benign but can potentially have harmful effects if it's not done correctly. To that effect, now testosterone comes as injections, comes as a cream. What is your preference of the method of delivery of testosterone? What do you prefer?
You know, testosterone creams work effectively, but the problem with them is you have to put them on every single day. You have to rub on every day. It has a black box warning if you have kids. I will tell you an interesting story. We had a patient that was doing very well with testosterone therapy, and then he was applying it every day, and him and his wife would get hot and heavy, and they would go at it. And then his wife came to the office like, "Doctor, I don't understand, you're treating my husband, and I'm just very frustrated with him." And I was like, "Well, how long have you been frustrated with him?" It's like, "No, for the past 6 months, ever since you've been treating him." And I was like, "Hey, really?" And so I learned through after trials and tribulation that he would put his testosterone on, and when they get hot and heavy, they jump in the bed, and he was rubbing the testosterone onto her, transferring it onto her, and then she was getting testosterone. He wasn't getting the full dose because he was sharing his skin gel on her. He was getting some, she was getting some.
Yes, because you're right. Absolutely, these don't, get absorbed immediately. So if you can go and you touch your, daughter or son or your wife, I mean, you can definitely.
There is a black box warning. If you're on testosterone gel, you cannot be around kids, or you have to put it on, cover yourself, cover the arm, wash your hands carefully. So I find testosterone gels really not useful. Now, testosterone injections have been around for the longest time. Ever since I've known myself, has been around. The problem with testosterone injections is they cause peaks and valleys. So I'll tell you another interesting story. So I had a patient that came in so many times like this. He would get a testosterone injection. About day 2 or day 3 of the injection, he would get about 100 to 200 milligrams from his provider, and then he would get in a fight with his wife. He'd get arguments with his kids, and he'd get a fight with his boss. He lost his job. So his wife brought him into the office. And I explained to him, every time you get testosterone injections at high doses, you cause such peak. The peak is what causes you to have aggression, anger, the sensation like that. And that's not good. That causes thickness of the blood. That causes elevation of estrogen. That causes anger, acne, fluid retention. You don't want that. So because we knew that, we tried to lower the dose of testosterone, make it more frequently. But now we have gone away from injections to the muscle subcutaneously. Subcutaneous testosterone tries to mimic the physiological response without those peaks.
So the subcutaneous takes longer for it to get absorbed into your blood. So you're not getting these peaks. And then because I remember when we used to do the injections in the office, by day 5, they had their peak, and then at the end they felt terrible.
Yes.
So it was like I felt great, and then I felt awful. It was just going up and then crashing down. Yeah. So the one that subcutaneous does not give that.
Yes, it does not. It's more steady. You kind of want to give the injection once every 7 days. You give an injection, you figure out the dose based on age match of the patient. The younger, the higher the dose; the older, the lower the dose. And you want to get injection every 7 days. You want to monitor their blood count because they can still get thick blood. And also, you can also develop high blood pressure from these injections. So therefore, you need to monitor your blood pressure, you need to monitor your estrogen level and your blood count and your PSA. You need a baseline PSA to know where you are. Yes. Because if your prostate, we expect 20% increase in PSA, typically based on where you are. But if your PSA increases by 0.5 or 0.75 per year or 1.5 per 2 years, on average, we look at that, the science of that number, we get concerned because if there is prostate cancer, that's how it's going to show itself.
Are you causing it to grow? Yeah.
Exactly.
That makes sense. That makes sense. So I also, just going back to sexual function, there's different parts to sexual function. I understand there's a lot of different things you're working on in terms of male sexual function. What are other aspects? So you can treat libido with testosterone. Then there's the part of erectile dysfunction, right?
Correct.
Does the testosterone have any effect on that, or are those all separate parts of it?
So as you get older, you may develop less and less vascular blood supply to your genitalia. Your nerves may become a little bit less effective. The blood supply to your penis becomes less vascular. You have more clogging of the arteries that feed blood to the penis. So therefore, if you have diabetes, high blood pressure, cholesterol, aging, chronic diseases, you'll have less vascular blood flow. So that's one thing. So you can have a blood flow problem or neurological problem.
And is that what's addressed with Cialis and Viagra, those type of
Those
medications?
drugs change the way how nitric oxide is metabolized and works within that area, increases the blood flow to the area, so they get better erections, they get more blood flow, stays there longer.
Okay.
But again, you need testosterone to give you that libido, that desire. So it's like a key and a lock mechanism. You need good blood flow,
Work hand in
you
hand,
need good
too.
nerve supply, you need good testosterone to make it all
Yes.
work. Because if you give somebody who's got poor blood flow testosterone, they won't get the benefits. If you get somebody who have low testosterone, the drugs like Cialis, Viagra, the drugs like that, they won't get the benefit either as much. So you need to make sure you maximize all of it together to get the maximum results.
Excellent, excellent. I really like your complete approach because, again, like you say, with testosterone clinics, they're just giving testosterone and that's it. They're not checking the rest of it. They're not looking for, is there, obesity involved? Is there diabetes, the vascular supply? Just other things need to be addressed. And I would guess the third part about it is now you've fixed half the relationship. You've given the male all the, supply, the testosterone, the medications such as Viagra and so on. And now what do you do when the wife comes and says, my husband is, has got high libido and I'm just not there anymore?
Oh, I think this is the best question of this podcast. I think that this is so real. We see this so often. You have a male who has a problem with erectile function. You give him drugs, you give him testosterone, you make him feel great, but you haven't done nothing for the partner. Now the partner comes back in the office mad as hell. It's like, take this guy off testosterone, he's chasing me, I don't have sexual drive, I have libido, I'm dealing with kids, life, I'm perimenopausal, postmenopausal, what have you done to our relationship? Now he's like looking everywhere. So This is crucial. I mean, when you treat a man with low testosterone, you gotta treat the partner too.
Absolutely, and I think this is what's going to lead to hopefully our next podcast. That will be the topic. But that's one of the biggest things I see because I treat a bigger female population is that the men have gotten treatment, they feel great, their libido is up, and a woman is just not there. They don't feel great. They're going through menopause. Their hormones are down, and it's when you have that mismatch, it actually causes a lot of problems. I got letters from a patient that was so upset because the husband had been treated and he felt great, and she didn't want to engage in sexual activity, and there was constant fighting, and it was leading him to have a lot of marital problems. So I think that's a really good topic. Would love to get your ideas on female sexual treatment.
Absolutely. I think we could corely work together on that topic, and I think that's very important because I get my fair share of hate mail and complaints with partners, and we try to address them. So when we treat a hypogonadal patient, I say, if I'm treating you, you're married, your wife has to become a patient, or she has to come to your visit so we can talk about what's missing gap to, because we don't want to ruin your relationship. We want to augment that so it's great for both of you guys. So one of the most important things we have is that when patients present to our office for endocrine workup, they usually have gone to the primary care doctor's office, which is your office. You are the front line. You are the front line where you see all the difficult cases. How do you navigate when these patients present to you with this concern about low testosterone and they're obese?
I mean, that's probably the most common thing that I see on a daily basis. When people come in, they're not happy about their weight, their energy is low, sexual drive is down, and I want to feel better. That's what they're asking me. So, and I think it's really, really important to remember that just dealing with the testosterone and doing testosterone replacement is not enough when you have a patient who has obesity. So obviously our first line is always going to be, what are you eating? What's your diet like? Do you have, are you taking in too many calories? How much exercise are you doing? So that is our first approach that I always take. But after that, there's patients who really do try and they just can't. They fail time after time. They go on these fad diets and they just can't keep up with it. And the GLP-1s actually have been fantastic medications. I've never seen a medication since I've been in practice over the past 20 years that's had such a big impact on people's lives. Since we've been able to, have patients on semaglutide, tirzepatide, they're losing weight, but they're not suffering and losing weight. They're still eating what they like, but smaller portions. And they always tell me, oh, the food noise, that's gone, that constant, what should I eat next? So that's been a huge, huge factor in patient weight loss over the past year. And once they have the weight loss, it's been so much easier to treat the testosterone deficiency, the estrogen deficiency, those things.
As a primary care provider, how do you see insurance companies when you write the prescription. How difficult is it to get these drugs approved?
Extremely difficult. I mean, to this day, really, once in a while we get one or two insurances here or there that'll cover it, but I would say probably for 95% of the patients, unless they're type 2 diabetics who've been on multiple medications, we are having a hard time getting it covered, which is a shame because there's not been a better medication that's ever come on the market with the least amount of side effects that I'm seeing that really makes such a difference. My patients are getting off their blood pressure medication, they're getting off their cholesterol medication, diabetes medication because they're losing the weight. And it's just, they're so much healthier, they have more energy, they're functioning better. But unfortunately, it's just not available to a lot of them.
Correct. I can just speak of my weight loss experience been running weight loss practices in clinics for over 20 years. I can tell you that, there are certain subset of patients, and no matter what they do, they just can't lose weight. Once you work them out from the endocrine aspect and making sure they don't have secondary causes, then you really have to go after them. And you're absolutely right, this noise about the food in the brain, because GLP-1s sit on the brain receptors. They have receptors everywhere. They slow gastric emptying. They cause satiety at the brain center. And this noise you talk about is so important because they just don't feel like they're eating. And the education is very important, how much portion control. So it bothers me so much that insurance companies deny these prescriptions because these patients live longer, they live healthier. And I'm very excited to know that as a primary care provider, you go after them and you try to get those things approved because it's a lot of work.
It's a lot of work, but it's actually been the most rewarding thing because I've had patients who've come in and they've lost, 20 pounds, 30 pounds, 40 pounds. One of my patients lost 80 pounds and they come in there in tears and they're like, doctor, I've tried weight loss for over 30 years and this is the first time I've actually been able to lose weight and maintain it. And I feel good. I'm not suffering. I'm not, trying to sneak little, bits of food here or there. I just don't want it. I eat what I want. I have smaller portions. And I'm losing the weight and they feel great.
How do you talk to your patients about the exercise post-GLP-1 and muscle loss with GLP-1? Because the metabolic rate is controlled by the muscle metabolism. And
that's actually huge. I'm so glad you brought that up because, sometimes people get on this medication, they're losing weight, they feel great, and they just kind of like, well, I'm losing weight, I don't need to work out. And the problem with it, as you know, is that, you're not only losing fat, you're losing muscle. So rather, you can just get weaker and weaker if you're not exercising. So we really, really stress that if you're on a GLP-1, you should be on some form of a, exercise program. You should be doing weights. You should be building muscle at the same time. Otherwise, you're going to lose muscle and you're going to get weak.
Correct. I know you guys have a in-body metric measurements in the office, which looks at your body fat,
yes,
your muscle, how much you have, because weighing yourself on a scale, I think is just so outdated.
It is, yeah.
It's just ridiculous.
You don't really get any, valid, you've lost weight, but what did you lose? Are you losing fat? Are you losing muscle? Is it water weight? Really it doesn't tell you any of that.
And we do know that muscle and longevity goes together. The more muscle mass you have, the longer you live. The more muscle loss you have, sarcopenia you have, the more problems you have, the shorter you live. So your longevity is dependent on how much muscle mass you have. So you want to preserve your muscle. And I'm so glad that you guys do this in the practice.
Yes, absolutely. Because you don't want to solve one problem only to end up with something else. The weight is just, part of it, and it is a big part of it. But once you lose the weight, now if you've lost a lot of muscle, like you say, it has such, effects in terms of longevity, people's balance, especially in older individuals, people who have some osteoporosis and so on, and falling and breaking bones. And it's a big deal to really, really be able to maintain that muscle mass and get strong while you're losing the weight.
In those patients who are obese, you make a diagnosis, you put them on GLP-1, do you screen their thyroid? How do you go about that usually?
Absolutely. That's the other thing, that there's a lot of clinics over, online, people are ordering GLP-1s and they really don't do the full workup. I require a full workup. They need to have their heart checked, they need to have a full blood panel, thyroid checked, make sure there's not something else underlying that's not being treated. Right. And then once that's done, it's really important also a physical exam to feel is there any nodules or any concerns, because there have been some studies, as you know, with thyroid cancer in rats, not in humans, but still you want to make sure, is there a nodule, could there be a cancerous nodule, anything like that, before you start someone on a GLP-1.
Absolutely, very important. And the cancer that we usually see with rats is medullary thyroid cancer. It's more of a rare cancer, but it's more of an aggressive cancer. It's indolent. It's one of those pain in the rear end cancers as endocrinologists that we see, because it's hard to eradicate and cure if you don't catch it early enough. So therefore, a neck examination should all be part of the examination. Also, one of the things that we see here is that sometimes patients have gallstones before they go on these medicines. They don't know about it, and they go on these medicines, and they really all of a sudden the gall they have an attack, and they really get into trouble at that point. They wind up getting pancreatitis. So I'm very excited that you take the time to look at the picture, which goes to say that if you're on these drugs for the management of obesity, weight loss, and testosterone therapy, you need a very comprehensive approach. You need to partner up with a physician that knows what they're doing and takes their time to evaluate the case, because you don't want to fix one problem, as Dr. Karami mentioned, and create 4 more problems. Then your life is going to be a disaster at that point. I think that's very good. I'm very excited to hear you guys do that.
And I mean, I think one of the other best things I've seen with this medication initially when I started using it is, there was the whole GI side effect, and I thought, oh my gosh, everyone's going to start calling me on the phone. I'm vomiting my guts out. I'm having abdominal pain. And I've treated I would say probably over 1,000 patients with this. And literally I've had 2 cases where the patients really had a lot of severe nausea and vomiting. Everybody else seems to say, okay, I have a little bit of nausea the first week, especially if I overdo it with food, but once they adjust their portions, they feel fine. And really, constipation has been the only thing that is manageable with stool softeners and so on. Have you had anybody with any severe side effects?
I mean, it's dose dependent. Not everybody's the same. I said medicine is always an art, and so how you paint it, the eye of the beholder. So I always say that one drug may work versus the other one. You need to start slow and gradually work your way up. This is a marathon, it's not a sprint. So if you go really fast and aggressive, then you may get more GI side effects. Cut your portion, hydrate extremely well with 64 ounces of water per day so you don't develop constipation, because that could be one of the symptoms. And go slow, take your time and educate regarding your diet, portion control. And when we put all of it together, very few patients have side effects unless they have unless they have irritable bowel syndrome, unless they have GI disorders.
That's actually a really good point. And those are the patients that I've been very hesitant about putting on GLP-1s. I mean, just yesterday I had a patient that severe IBS, and she was insistent and she really wanted it, and I really had to talk her out of it, because in the IBS patients, it really does exacerbate their symptoms. It's just not the patient, who really should be on this medication.
Correct, exactly, very good. Well, thank you very much for your time. Thank you for good insight into what goes on in your frontline war with all the cases that you have. Thank you for sharing that during this podcast.
Pleasure.
It's an honor to have you here.
Well, thank you so much. I think this was a lot of good information. I think I can use it in my clinic. I think people can get educated and know what signs and symptoms to look for. And in terms of treatment, hopefully get the treatment safely with a trained professional like yourself.
Great. Our role in this podcast is to bring maximum education to patients and colleagues so we can have an educated discussion, bring the topics on board, and have multiple guests and expertise, because it gives me great honor to bring someone like you to this podcast, because you have wealth of knowledge and experience on the receiving end of the patients, because we as specialists, we deal with these patients. You guys get all the difficult grunt work of all these cases. So I really appreciate you being here today. I want to thank you guys for staying with us on this podcast. I really appreciate your attendance. We hope that we can bring lots of good information to you. Share this podcast. If you like us, please follow us for more exciting topics. We'll bring multiple guests and different topics that are very relevant to your daily life.